Good morning, good morning, good morning, and welcome to the Great Lakes Health Radio program on Power 96.5 FM, WUFO 1080 AM, with your host, me, Francesca Messiah, from Kaleida Health, Manager, Workforce Development. I want to thank you, and I greatly appreciate you listening to the radio program, and I enjoy hearing the comments when I see you out and about in the community. I enjoy hearing your comments, and I'm always going to ask the question, is there a topic we've not covered and you would like to hear? Our topics include all ages, so there's never anything in the area of health, education, or career that we can't cover. Well, who is Kaleida Health? Kaleida Health, we are hospitals. We're hospitals. We are in Buffalo. We're in the North Towns. We're in the South Towns. We're in Olean. We're in the Southern Tier. We're Buffalo General Medical Center, Millard Fillmore Suburban, Oishei Children's Hospital, Gates Vascular Institute, Visiting Nursing Association, DeGraff Medical Center, Long-Term Care, or DeGraff Long-Term Care Center, as well as High Point on Michigan. We have specialty practices for adults and children. And we're also a full service cancer provider, Great Lakes Cancer Care Collaborative. However, the name will be changing soon, but the services provided will be the same. If you haven't taken a look at our career site, that's www.kaleidahealth.org/careers. We have over 900 openings, and our openings range from high school degree through a PhD and everything in between, clinical and non-clinical. Well, today it's it's our program. Our first half hour, we'll be speaking with Mr. Robert Baxter, who is principal and head of schools for the Health Sciences Charter School. Sciences Charter School, the doors opened 14 years ago. They are doing amazing things, and students are on their way to all types of careers. And our second guest that we have for today is Dr. Leonard Leggett, and Dr. And on that topic, we will be discussing health. Dr. Leonard Agete. I think I said Leggett, but it's Dr. Leonard Agete. And we will be discussing health inequities and population health in Western New York. And that's our second half hour, I'll guarantee you'll learn a lot in that both the first part of the show as well as the second part of the show. So on with the first part of our show. In our studio, we have I'm going to say Dr. Robert Baxter.
I'll take that.
You'll take
that title.
Mr. Baxter is principal and head of school at Health Sciences Charter School. Where did you start as a biology teacher, Mr. Baxter?
Yeah, in my career, Fran, I started off as a science teacher working in Buffalo Public Schools and then Westminster Charter School. I claim to fame, I also in the summer worked at Roswell for 18 years doing their high school biology of cancer class and research program. So I've done more science-focused teaching and collaborations than I've done being an administrator of the school.
Oh, but I'm sure. Well, it's great preparation. I mean, being in the field, all of your entire career, I know has given you a head start on the Health Sciences Charter School, which did open their doors 14 years ago, educating high school children and providing opportunities to learn about careers in healthcare. Have you been with the school the entire 14 years?
No, I came in 2013 In 2013, became the school's first assistant principal. Back then. When the school started in 2010, as charter schools start, they started with a grade level at a time and add on. And so I came in the nick of time as they were growing as their first assistant principal in 2013.
And I remember when the school, for the year before they opened the doors, because my supervisor then, Melva Bisher, was one of the founding board members. And 14 years for a charter school, I know is excellent. And listeners, 14 years is excellent for a charter school. And Mr. Baxter, what do you owe to the success of the Health Sciences Charter School?
Well, we have on our board that helped to start the school. You know, somebody was ambitious enough to look into the future to see that, you know, there was going to be a shortage in healthcare workers. So on our board now that all the different hospitals, health insurance agencies, higher education that serve on our board, that really helps to make it successful. And so they're very supportive of our endeavors. And we're finally reaching the road where it's paying off with the finished products of young people going into these health careers. So it's definitely up to my board and the success of the school.
Now, since 2013, how has, I mean, in your opinion, how has the school or the curriculum changed? I know that when it first started, we didn't have the sports and such. And how has the school changed in your view since the doors opened 14 years ago?
Oh, yeah. Well, remember, like I said, in 2010, we were just starting. So by 2013, we finally had a full school of 9th through 12th graders, right? 2014 was our first graduating class. So at that time, imagine building a school slowly. They didn't have a lot of the high school experience items as far as clubs and sports and things. And so when it came, we started adding those things on. And so to the point where now we have a football team. So small schools like us didn't normally have a football team, and we have the full complement of sports for boys and girls. We also added the different clubs, activities, our Young Doctors Club. We got drill. Our kids are putting on a play. So we add something every year to the point that our alumni are comment on our social media saying like, geez, you didn't have that when we were there. You keep adding things, you like them better.
Yes.
But yes, the main thing I like, Fran, is where we're going, the ultimate mission of the school and getting young people into healthcare careers. So now with our work-based learning program, our focus on college and careers, we received a grant last year, the Stronger Connections grant. We were one of 44 schools across.
What is that called? The what grant?
The Stronger Connections grant.
Stronger Connections. Yep. Okay.
It was a grant put out by New York State, which we are one of only 44 schools in New York State that received this grant. And I think our application was unique in that fact. And the grant that we were awarded for, it was $680,000 to bring back CNA, LPN.
Acronyms. We have to spell it. You got to say the whole, what it means.
CNA is a certified nursing assistant.
Thank you.
LPN is a licensed practical nurse, right? And we do a lot. Our school was established as a social justice mission, not just to bring people into healthcare, but to bring minorities specifically into healthcare at all levels of healthcare. And so to that end, we saw fit to bring back CNA and LPN. On the east side of Buffalo, there was no LPN program. The last one we had was back at East High School at Buffalo Vocational Training Center. So this is kind of a restorative to the community because we find our students prefer to be in their community, in their neighborhood, learning these things. So we're excited, Fran, when the next time you come into the school, We got our 2 hospital beds that just came in this week. The mannequins are up there. All
Oh my
types of
gosh.
equipment for the program is coming in. So we're really excited about this programming. And so this is going to be one of our anchor programs. But as
Hmm.
we tell parents and students, there's over 100 careers in the health sciences. Like, I love the work that you do over there at Kaleida, Fran, and we find it very helpful in exposing our young people to these careers and making choices. And so
Hmm.
I've already gotten feedback in the time that I've been here, like young people who've been exposed on a trip or a career or on an internship, and they wind up working at that same hospital or place of work where they did their internship. So we know it's paying dividends. And so now we're ratcheting up the programs and to have more programming and more certifications for our young people.
Yes, no, that's so important. Now the mannequins. I don't know if our listeners know, but are these the mannequins that you can perform blood draws or do different things, and the mannequins scream? Or is that the mannequin? Are those the ones that you have?
So the mannequins, we have 3 or 4 different mannequins right now. So
Mm-hmm.
in this first phase of our grant, it's a 3-year grant. So in the first phase of the grant, we're getting the mannequins that allow for the training for CNA, which is the most basic level of nursing. Once we go into the next phase, we're getting more sophisticated mannequins in that. But yes, we're moving in that direction where they can do blood draws and everything else.
Yes, so our listeners, I mean, the mannequins in the healthcare field are very sophisticated, and they want them to mimic, even though it's a mannequin, exactly what it would feel like if you were any. And Principal Baxter mentioned in the hospital beds. So it's a hospital bed with a mannequin, as if any of our loved ones were in this hospital bed, but they can do things such as put in a catheter. And
Yep.
they can take blood draws. I mean, and the mannequins, I don't know how they program them, but the mannequins are programmed that if something doesn't go right, the mannequins actually make noise.
Right. They respond.
They respond. Yes, I should say they respond. I think that is amazing. Now, how about graduation rate? I remember again being part of the school when they through my supervisor then, Melva, and I know that you've had students who have gone on in the 14 years to become physicians, or or else they're in medical school. They're probably physicians if it's 14 years ago. But could you just talk a little about some of the careers over the past several years that just a few, just to highlight a few of the careers that students have gone into, and talk about class size?
Yeah. Well, simply, if I encourage listeners, if you go to our social media, our Facebook, Instagram page, where all of our alumni kind of respond. And so if we put anything out there, you'll see that a lot of our alumni are currently your nurses. We have doctors and physician assistants. We have a bevy of people in healthcare who came and were encouraged to go that pathway here. And so as we expand that program, what I didn't talk about is our Healthway Career Training Center that we're developing for those alumni and that 18 to 34 crowd, right? Where they can get specific training, which we are working with different unions and organizations that will pay for that training and provide stipends for our young people to get that healthcare training. So if you're out there coming in the new year, well, this healthcare training will be available. And the beautiful part about it, Fran, it's tied to, we have a working relationship with employers that we're trying to actively work with these unions to get these folks jobs and placements when they're done.
Yes, because I know many students when they come out of school, I mean, some students, and your school is no different than any other. Some students want to work right away, and some students want to go to college. And it's nice that they have a choice.
Oh yeah.
You're able
Oh
to
yeah.
give them a choice.
We have folks who go right on to college. We got folks who go right into careers. And so this is why we're so excited about CNA, because they can, in their senior year, take and become certified for CNA and go into an employment. And those employers, we are utilizing the benefit of going and doing further training while they're working. So if you're a CNA, like, hey, they're willing to pay for reimbursement to do tuition reimbursement while you're going to school to be an LPN, all the way up that path line. If you want to be a physician's assistant, so it's exciting. So they
It
have.
is. You want to be a radiologist?
Yep.
We have it.
Yep, we got radiology too. We just met with Dr. Deeb over at Trocare yesterday. We're very excited. Remind me to tell you about that program. We got some exciting results happening. Our young people go to Trocare for dual enrollment classes, meaning that they get credit for high school and credit for college. And their cost is very minimal to them. We pay as a school the majority of the cost for this program, and they're leaving here graduating with not only their high school diploma, but with several credits towards a certified degree program. And they carry on and they go at the different places that we do enrollment at Trocare, at Villa Maria, and we're working with other areas and other pathways. And so we talked to Dr. Deeb yesterday about exactly that and doing radio technology and ultrasound. There's a need for that. So exciting. Our young people, friend, are going to Trocare. They're in classes with regular students who've graduated high school, who may be returning back to get their, maybe older and going back to getting their certification, become an RN of that. Incredible. The report that we got yesterday were that our young people are on par with the adults that are going there, and the professors love our students more so than the regular adults.
Well, you know what? It's about exposure, and the beauty of it is that you're exposing the students at a younger age. Before I move on to the next question, I'm going to say there could be someone who's interested in having their student enroll either in the fall or maybe in January. What's the application process? If you could just give us a little information on how can someone get their student, at least the name, on the list?
Well, here, real simple. For if you are out there listening and you want to get your child involved at Health Sciences, the high school, you simply go to our website, healthsciencescharterschool.org. In the bottom right-hand corner is our application to the school. And so as a charter school, if you're thinking of for next year for your child, that application opens December 1st. And all charter schools in New York State have to do a lottery to get in. So we usually do not have to turn any freshmen away. So freshmen have the higher capacity to get into the school as opposed to 10th, 11th, and 12th grade. But we do take applications for all grades. And that application opens up December 1st. For the Healthway program, as we're putting that together, that's expected to open up in the new year. So when that comes out, it will be on our website for people to apply and be a part of that program. And again, that is open up to the 18 to 34 crowd, and no age discrimination. We want everybody and moms. Our ultimate goal, friend, is to be able to have maybe a mom in the house potentially going to school with one of their kids, and it all being in the health science family, all the way down to kindergarten. And
It's another version of All in the Family, All in the Family. And you know what? I can't believe. Well, we have about 8 more minutes or so left, and we have to have a part two because we haven't even gotten through half the questions. Student work-based learning. If you could, not only could you talk about student work-based learning, if there's anybody out there, I know I was recently in a conversation. I forgot what meeting it was, and we were talking about students volunteering or internships, and someone said they wouldn't mind taking a couple of students. I believe it was one of the unions that was one, and I had someone else. If you could talk a little bit about student work-based learning from what it means for the student, and if a community member is interested in assisting as a student with their work-based learning and receiving credits towards high school graduation. If you could talk a little about that.
Oh, yeah. So in New York State, and in New York State, to their credit, the Board of Regents is getting more innovative in pathways for students to graduate. And work-based learning is one of them. And so simply here, we believe, my philosophy is people don't know what they don't know.
Yep.
If you don't expose them to different things, then how do they know they don't like it, or how do they know they do like it?
Mm-hmm.
And so our goal is to expose people to as many careers as possible. And when we expose them to these careers, all the time I get people that come in and say, hey, I want to be a nurse. I want to be a doctor, until they see blood, right?
Right.
And then until they experience death. I have students who became doctors and nurses, and where they happen to work in hospice area, it was too much for them. They changed careers.
Mm-hmm.
And we simply tell people, if you come in and hey, you can be an administrator. You don't have to see a patient at all. Or everything is not about being a doctor or a nurse. And so in the work-based learning program, our young people are able to go to our different partners, hopefully first the hospitals and healthcare places, but secondarily for our students that say, hey, I think I might want to be a hairdresser and things. Well, we're willing to put that person in that setting if there's somebody's going to teach them the skills of being able to working for somebody, soft skills, how you handle customers or patients and people you have to deal with who are usually not at their best if they're coming to the hospital, right? And so they get to learn all those soft skills and get feedback. We do mock interviews and different things with the young people. In fact, we got a mock interview set up, and we're going to expose people to civil service exams and the different careers that are available to them right now in healthcare. So long story short, Fran, as we do this, they also get to graduate with work-based learning credits or work-based learning CDOS pathway, career development opportunity pathway. And that can take the place of one of the dreaded Regents exams that we all hate. I did very well in them, but finding that they're probably antiquated now. And so the Board of Regents of New York State are really making changes to allowing real, authentic learning opportunities. And so I'm happy because we're above board and ahead of everybody else.
Wow. And then again, if a company wanted, because I know I was speaking with someone, and I think it was either Medicare reform, someone is interested in having a student working along with them and learning how to write policy. So in terms of work-based learning, it's a very broad area. So how would someone get in touch with you if they were interested in hosting a student and learning more about the hours and what it means, what this means? How would they reach you?
Oh, yeah. So I have someone over that department, Dominique Petway. She's over that and placing students in the work-based learning situations and internships and following them up with them. But simply anybody out there, if you can contact me, we have the longest email in the history of emails. So simply you can email me at rbaxter, BAXTER, at health sciences plural charterschool.org. We'd love to work with people who want to work with young people and knowing that they got things to learn and they're not coming a finished product, but we want people who are going to be part of making a finished product.
Mm-hmm. No, thank you. I know we have 3 to 4 minutes left as we wrap up the interview. Something else I thought was very innovative about the school. Let's talk about the food to farm program in the garden. Where? Oh, I forgot to say, where is Health Sciences School located? As I'm talking about the garden across the street, we haven't even identified where is the school.
Yeah, the high school, we're located at 1140 Ellicott. So those of you driving down Main Street in the heart of the city of Buffalo, if you know where Delta Sonic is, we're 1 block over on the east side of Buffalo on Ellicott. And
I think it was a Catholic school, maybe an Archbishop Carroll years ago. And before that, it was an orphanage, as my mother used to share with me.
Yeah, so, it was actually, Fran, Bishop O'Hearn High School for Girls.
Okay.
I got an interesting story. Bishop O'Hearn High School for Girls. This is where my mother attended.
Oh, okay. All right.
Across the street, Fran, across Main Street, right next door to Delta Sonic right there. They tore the gymnasium down, so you went.
It was Fallon.
As a school. It was Bishop Fallon.
Fallon, yes.
That's where my dad attended.
Yeah, my cousin.
Yeah. So I tell everybody, I'm like, hey, I need to know which one of you crossed the road. Like me.
But in our last minute, just a real blurb, a quick blurb. Food to farm. Maureen, I think, is running that. What is? I have 1 to 2 minutes left. So just one word, just a couple of sentences about food to farm, if you could share.
Yeah, we believe in the food desert. We found out a lot about that, and more people were educated during the top shooting in that of what's going on the east side, right? And so we did a farm to table grant and from the USDA, and simply teaching young people. We have a garden over here teaching young people how to grow food. We incorporated that food into our smoothies that we would do on Wellness Wednesday, and then in the mornings, teaching young people how to exchange good, healthy food and training them about good, healthy food and taking it in, getting those extra fruits and vegetables in their diet, which is more palatable in a smoothie, and you can get a bunch in. And so they learned how to grow food. They learned about the soil, about the proper way. They were planting the food and harvesting the food and utilizing it in the smoothies. And that's morphed into our nutrition classes that we do in school and after school. And our goal is to be healthy, not just in knowledge in our head, but in practice.
Yes. And on that note, Principal Baxter, I just want to sum up a couple of things. Health Sciences Charter School, it's 14 years in existence, high school. They have a fully accredited sports program for young men, high school men, boys, and high school girls. Also, the farm to food garden. There's student work-based learning programs. There's internship programs. There's athletic training programs. There's certified nursing assistance programs. That's just to give you a sample of what we've been talking about, because I have to say thank you for being our guest this morning on the Health Sciences on the Great Lakes Health radio program. Thank you so much, Mr. Robert Baxter.
And thank you, Fran. Thanks for having me.
Thank you. And listeners, don't go away. In our next half hour, we have Dr. Leonard Agate, and Leonard Agate, and he will be talking about health inequities and population health in Western New York. Stay tuned. We'll be right back. And now on to part 2. Good morning and welcome back to the second half of the Great Lakes Health radio program on Power 96.5 FM, WUFO 1080 AM. I'm Francesca Messiah from Kaleida Health, Manager, Workforce Development. And the second part of our program, we are going to be talking about something, and I know you've heard about it in the news and workshops and seminars locally, nationally. Our topic is health inequities and population health in Western New York. I know you've heard the term many times, health inequity. You may or may not have heard the term population health, but we have an expert with us, new to our Kaleida family, and that's Dr. Leonard Ogeti. Good morning, Dr. Ogeti. How are you?
Good morning. Really glad to be here and excited.
Oh, yeah, good. And I suppose Dr. Ogeti is the medical director of clinical research for Kaleida and ECMC, and the medical director of population health for the Great Lakes Integrated Network. Kaleida is affiliated with several health entities throughout Western New York and Pennsylvania. And so the Great Lakes Integrated Network called Glenn will do that. We'll have another program where we talk about that. But the topic for today, when I began researching the topic and all of Dr. Ogeti's work, I said, how can we do this in a half hour? So Dr. Ogeti, if you could please share with our listeners, and why is it important for Kaleida Health and really all healthcare systems to address health inequities, and what do they include? And is it just health inequities or is it all inequities?
Yeah. So I think, thank you, Francesca. Just to add, I'm also the chair of medicine at the University of Buffalo. So I do have an appointment at UB. So that's important to include. So I wear many hats, but I think this, one of the things we really need to pay attention to is the fact that when we talk about health inequities or health inequalities, it's really an issue of how healthcare differs for different groups of people, right? Ideally, you should have a system where it doesn't matter who you are, how old you are, how young you are, what your race, ethnicity is, your income level is, you should get the same care. But that's not what happens in our healthcare system. Our healthcare system is really set up in such a way that certain people are at an advantage and certain people are at a disadvantage. And so when we use the word health inequities or health inequalities, we're saying those differences in health outcomes that are not consistent with what we would expect. So the way we typically address this is the concept of when you look at different population groups, different groups of individuals, if what is expected is different, we say there are differences, right? But then we begin to worry about those differences if those differences cannot be explained by the patient's preference or the standard of care. So if certain groups are getting lower standard of care, certain groups are getting less access to certain treatments, then we use the word health inequalities.
And what would be some examples of you said less, would you say less treatment of care? What would that mean?
So if you look at across the board, if we take cancer, for example, right? Screening for cancer is lower in minority groups. Even for the same level of cancer, the treatment options are not the same for minority groups. And then the survival for cancer is very different by group. Now, traditionally, people have tried to say, well, it has to do with biology, but we found as studies have been done over and over again, it is not really biology. A lot of these things are social issues in our society. So we call them structural factors. And so there are issues that are tied to the greatest driver of these inequities is access to care. What is access to care? Do you have insurance? Right? But we also know that insurance, there are grades of insurance. And so whether you have private insurance, Medicare or Medicaid may vary. It may affect how you get certain services. So that in and of itself is an access issue, which is why those who do not have insurance have poorer outcomes. And insurance and access are tied to income level. So if you're employed, you have higher income, you're more likely to have access. So access is a key driver of some of those disparities. But then even when you have access, when people come into the healthcare system, there are issues about bias, stereotyping, right? Things that happen where people are making decisions about you based on how you look, how heavy you are, your gender, all of those factors play a role in how decisions are made. And those are the things that once you get through the door, the things that drive outcomes.
Wow, that's interesting. And I also want to mention, because I read recently on LinkedIn about an article that was featured in the National Institute of Minority Health and Health Disparities, where you talked about the structural racism and the impact on health outcomes. So I want to say congratulations on your article that was recently received national recognition.
Yeah, thank you. Thank you.
You're welcome. And I apologize about missing your title for UBMD, UB Medical School. And I have to say, Dr. Archer did remind me just the other day about your title. He said, and he is. So
that's okay. That's okay. Yeah. We're all learning.
We're all learning. Well, and now for population health. As medical director for population health for the Glenn Network, please explain how population health, does it complement health inequities? Is there overlap between the two? I was trying to get a grasp on population health. And what is population health?
Yeah, so I think the way to think about this, when we use the word populations, we are talking about groups of people, right? Right now, the care we provide is very based on an individual level. So you come in, I see you as a physician, I treat you, and I'm done. The issue is that many times when you have systems of care, when you take groups of individuals, so let's say, for example, you take all patients with diabetes who come to Kaleida, right? You can create systems of care that allow you to standardize care for that whole group. So you move from population health is when you move from an individual-based care to a system that accounts for all the individuals who actually access care in that health system. That's a more efficient way. It's a better way of providing care, and it allows you to leverage your resources to improve the care you provide. But at the individual level, it actually improves because we say that when the tide rises, all boats float. So if you create systems of care, then everybody benefits. So actually, population health is one strategy to address health inequalities because it then creates systems that ensure that anyone, regardless of their race, their ethnicity, their income level, gets the same standards of care.
So population health may, if it's looking at populations, it might look at zip codes because the health inequities could look at zip codes and show that there's a population who's in like 4 or 5 zip codes who are dying at an earlier age, or the treatment, something like that?
Yeah, absolutely. So once you get to population health, you move away from just the individual and you start looking at groups, right? So for example, you could take if you actually were to look at mortality rates, you look at disease control rates across the enterprise, right? You can actually identify what we call hotspots. Hotspots are areas where the care is not at the standard we actually expect. So if you can identify those hotspots, you can actually say maybe there are 5 zip codes in Western New York where the outcomes are the least desirable. You can then focus your emphasis on those zip codes. You can generate resources. You can use healthcare workers, community workers to actually help address some of those issues. Also, once you go to population health, you start looking at things like transportation, housing, food, because now you are we argue, and I think most people now understand that people live in environments and the environment matters. So as health systems, we have to start paying attention to where people are coming from, what are those factors happening in the environment, and how can we help support some of those issues.
I was recently part of a conversation a few weeks ago with the NAACP, and the physician talked about, what did she call it? Maternity deserts? It was where women lacked access to maternal care.
Yeah.
Are you familiar with that?
Yeah. So I think we use the word now. We talk about food deserts. We talk about transportation deserts. I think the concept maternal deserts is the idea that for pregnant women, it's very difficult for them to get access to high quality care because of where they live. So if you look at certain zip codes, the closest medical center, the closest gynecologist, the closest OBGYN may actually be very difficult for them to get to. So if you're going to have to take multiple buses to get there, you can imagine that the care they actually receive will actually be not be great. So that's the concept of deserts in healthcare.
Yeah, I just thought that was so interesting. Dr. Chris Purnell was just very interesting. So for the next I have here 5 to 10 years, but that's a long time. I'm going to say the next 3 to 5 years and include and beyond. Based on your research, where do you see health inequities and population health, or what systems need to be improved sooner rather than later to stop the bleed, as I'm going to call it?
Yes. So I think first and foremost, we need to move from individual care to population health care. What that means is that we need to actually move from one patient at a time to actually thinking about systems and groups of people. What that will allow us to do is we can define groups that are not doing very well and invest resources to help those groups of individuals do better. So for example, something as simple as lung cancer screening. We know that smokers, people who have smoked for more than 20 years of smoking, at a very high risk for lung cancer. There's now the ability to do lung cancer screening using CT scan. But what's happening is that only about 10% of people who are eligible are actually being screened. What that means is that we're actually missing out on identifying people who are likely to develop cancer before they develop it. So you can imagine if we actually had a system in place where we actually focus on, I know we have that, there's work going on right now, but if we actually had a very clear system of identifying people at risk and screening them ahead of time, we can actually prevent a lot of lung cancer. That's one example. Same thing with breast cancer, same thing with colorectal cancer. So I think screening at the population level is very, very critical. But the second thing that I would like to see us begin to do more of is what we call a more holistic approach to healthcare, which is paying attention to social and medical factors, that the individual has medical needs, but they're also social needs. How can we integrate medical and social needs and create a more holistic approach to healthcare? What does that mean? Well, things like transportation, housing, food, right? How do we actually ensure that we are asking those questions in a healthcare space? We are referring people to resources that are available. New York actually has one of the better systems in place for some of these social issues, right? So it's not a question of, you don't have to actually pay for it. Most of it is really making sure you connect people, you become the connector. So when you go to population health, you can actually say, we have X% of our population, of the patients we see who are housing insecure. How do we get them connected to housing? Those who are food insecure, how do we get them connected to food? Those who have transportation barriers, how do we get them transportation? That allows you to provide care in a way that maximizes what people are able to receive.
Yeah. And you talk about food, and I always talk about food on many programs. How important is what you eat connected to your health? And
you know the answer. You know the answer to that, right?
What about medical?
Yeah, that food. We use the word now. Food is medicine, right? The concept is that we over the years we have enough data now to show that what people eat affects their health outcomes. We have an obesity epidemic, right? We have a diabetes epidemic. People are actually struggling right now, and a lot of that is tied to the kind of foods we have available. Most of the cheap foods are not healthy, right? So if you actually were to, if you have financial challenges or financial difficulties, the kind of foods that are available to you are not really the best kind of food. So I think paying attention to how do we get healthy food available to people? How do we incentivize people to eat healthier so that as a population, we can actually get healthier and have better outcomes?
And that makes total sense, because what you just said, between obesity, that's one layer. Diabetes, that's another layer. Lack of exercise, that's another layer. But when you group it into population, it sounds like you can, and health inequities, but definitely population, you can really begin to see a story.
Yes.
Or a pattern.
Exactly. And I think what happens is, instead of treating one person at a time. You can just create programs that will cover 5,000 people, 10,000 people, 100,000 people. And I think at that scale, one is cheaper to do that because you don't have to do one person at a time. You actually learn what works. You can deploy what works at scale. So I think it's a population health is really, in my opinion, is the next frontier. How do we care for populations, and how do we move from acute care to more preventive care?
And I guess for listeners, another example, correct me if I'm wrong, when you go out in different communities, let's say, I'm going to say suburban communities, you see everybody walking. The sidewalks are all the same level. Streets are lit. And, and then people say, oh, why aren't those people? Because in Buffalo, many of our communities, our sidewalks are uneven. The streets could be, well, the streets are lit. But sometimes if you're running, people may think you're running from something. But in other communities, when people are jogging or just walking, nobody stops to say anything. It's just normal. And I, in a walkable community, if you haven't been, listeners, if you haven't been to a walkable community, just go and see what it, in terms of population. And now it's making sense to me.
Yeah. So I think this is part of when we use the word structural factors, right? These are some of the structures. So how roads are, the decision on where you put roads, right? How communities are divided by roads, the housing structure in that environment, the green space in that environment. So if you go to certain neighborhoods, you feel calm, you have green space. There are trees. You feel like, you feel relaxed. Other neighborhoods you go in, you're stressed out. You have boarded up houses, graffiti on the wall. All of those things are things that affect both physical and mental health. Then when you start thinking about violence, right, in communities where you have violence, so it's not safe to walk around. So for many people, they don't pay attention to the fact that while you want to exercise, the safety of your neighborhood affects your willingness to go outside. And so if you're going to walk around and you are worried about your safety, or there are actually no paths to actually walk, it makes it very difficult. So these are things where I think changing some of the structural factors, the policies, and how things are actually done will make a huge difference.
Now, you also are an instructor at the medical school. Are you an instructor?
I'm a professor at the medical school.
Professor. So what course, so the course that you teach, what's the name of it? And does it tie into what we're talking about today?
So I think the way the medical school is set up is that we have a series of courses now that cover a lot of these issues, right? And so all the way from community engagement to social medicine, health inequalities, structural inequalities. So those are all courses that are part of the medical school curriculum. And now we are having more immersion of medical students into community work, having them be exposed to these issues very early on in their training so that they actually have a sense of what really happens and what it looks like outside of their medical school environment. And I think Western New York is actually unique because we have multiple hospitals. So whether you go from Buffalo General, you go to you go to the VA, you go to the ECMC, you see the breadth of what the environment has. So I think that's actually a great training opportunity because people are able to see patients at different levels, different socioeconomic strata, different race, ethnicity, different income levels. So I think it's a very good training environment because it gives people exposure to multiple aspects of health.
Yeah, I know even my primary care physician one time, there was a dental student in there and it didn't bother me, but I thought that was good because I know he's training the dental student to work with different populations. And this was a few years ago, so I'm not even sure if that's part of the dental school curriculum because for our listeners, dental school is separate from the medical school. Yeah, but I just thought, right.
Yeah. So let me give a shout out and actually an appeal on both sides. So for patients, please allow people to have trainees in the room. We have many patients who say, I don't want the students. Well, how are people going to learn if you don't give them a chance to actually learn? So we need to be open to allowing students to be part of that encounter. But then for the physicians out there in the community, we need sites. We need people who are willing to take students because the students need places to learn. So if you're out there listening to this, please open up your practice to allow students to actually come in and get trained.
Okay, so getting back to the patient, the listener, or it could be a physician, but what are like 4 or 5 questions? Because I used to talk about this. I haven't even addressed it in a while. What are questions that patients you recommend should have written down on a piece of paper so they don't forget to ask their physician? Many times, especially for 18 years at Kaleida, I was in the community all the time, did over 125 outreach events a year. And people would always share with me how I would say, well, did you ask your physician, your primary care? And they didn't. And I'd always, or they forgot. And I'd always say, but you should try and remember to write questions down. And I know years ago they had when I first started, it was called Ask Me 3, but I always thought that was not enough questions. What are some primary, to begin a dialogue? Because I always say physicians aren't mind readers. They cannot read your mind, so you have to have questions. You have to start that. You have to have a dialogue with your physician. As a physician, what are some of the top questions you feel that the patient should have, written down?
Yeah, so I think I can tell you that for as a physician, one of the things that is challenging is a patient comes in, they sit through the encounter, and then just as they're about to leave, they say, "Oh, by the way." Right? And my question is, why didn't you just tell me this when you first came in? So I would say, write down your questions or symptoms or things you're worried about upfront. So when you get into the room, the first thing you're saying is, here are my concerns. So then the physician can then allocate their time based on the concerns you actually provide. So I think that's a question. The first thing is, what are the things you actually want the doctor to address during that visit? Don't assume that they're just going to come in and they're going to figure it out. You should tell them, this is how I'm feeling. These are the things I'm worried about. And actually have that written down so you don't forget. The second thing is to actually have them go through your medications. Right? Go through your medications, because sometimes I have had many patients who are on 5 different medications doing the same thing. Someone wrote the prescription here, someone else wrote the prescription there. So we call it medication reconciliation. What should actually happen is ask your doctor to look at your medications, and if possible, bring all your medications, even the ones you take, at night, the ones you take in the morning, the vitamins, or whatever you're taking, bring them all in so that the doctor can review them and say, this matches what you're doing. This matches the treatment we actually have. But another component of that is asking your doctor, what do these medications actually do? Right? Which are the medications for diabetes? Which are the ones for blood pressure? Which are the ones for my cholesterol? That way, you can actually, you yourself as a patient, actually know, okay, this medication, these 3 medications are for my diabetes, and you can actually align that with the treatment. Because I've had many patients who say, are you getting any treatment for your diabetes? No. But then I look at the medication list and you have 3 medications. So they're actually being treated, but they are not aware. And then I think the other thing that the 3rd or 4th question I would say is, talk through your labs. What did the results show? Got some blood work done. What did it show? Right? What should I, what is normal? What is abnormal? And then finally, as you're about to leave, what should I do differently?
Yes.
What should I do differently? And sometimes the conversation goes like, oh, well, you're doing great. With nothing else to do, just keep doing what you're doing. Other times, hey, your cholesterol is higher today. Your kidney function is beginning to go down. We need to do the following. And I think having that closing conversation about what should I do differently based on the visit today allows you to actually know what needs to get done next.
And you know what, Dr. Getty, I think you're going to be a guest sooner rather than later to talk about. I haven't had a conversation on the show in years about general for adults on what to ask your physician and why things are important. I mean, this is November and we're just talking about this. I feel like I'm failing the listeners. So thank you, and I'm glad that we can have another conversation. So health inequities, population health. Back to the topic. is there anything the consumer, the listener can do to assist you, assist studies? Is there anything they can do, for to making sure that their health is equal or equitable, and anything they can do to make sure their health is equitable?
Yeah, so I think the first thing, going back to what can I do, I think the first thing is as an individual who receives care, follow the recommendations of your doctor or your provider. Many times we actually say that only about half of the prescriptions that are written are filled. So if someone writes you a medication for treatment, take it, right? And if you don't believe that doctor, get a second opinion, but do something, right? So I think one thing people can do is take your medications and follow the recommendations of the doctor. And if you have questions, get a second opinion. But the second thing people should actually be paying attention to is a lot of medical decisions are based on clinical trials.
Mm-hmm.
What that means is we're doing studies to understand what is the best treatment. What we find is that a lot of patients do not participate in trials, and then they are surprised when we don't have enough information to make decisions. We need that. We need those studies, those trials. So I would encourage people listening, if you have a chance to participate in the clinical trial, a study out there, please participate, because it allows us to gather enough information, especially from minority groups. Many minority individuals are not included in studies because they are not participating. We need more people to participate so the results are consistent across all groups, and you can actually say we're informed by those trials. And then obviously the third thing I would say, and I said this previously, help our trainees. Help our trainees, allow your doctor to bring in trainees, and actually you should be asking, are you helping train other people? And that way, because that allows us to create that tradition of actually having patients understand the importance of trainees being able to get training as they receive care.
Well, thank you. And on that note, Dr. Igede, we are out of time. It seems like we just started the conversation, but we are out of time. I want to thank you for being our guest this morning on the Great Lakes Health Radio program. And I want to thank our listeners for listening to the program. And next week, you'll hear from my esteemed guest, you'll hear from ECMC's radio host, and that is Cindy Bass. And in 2 weeks, God be willing, you will hear myself, Francesca Messiah, Manager, Workforce Development, Kaleida Health, and another interesting guest from the Kaleida Health system. And until then, be good. Bye-bye.